to introduce Frank Lieberman, a colleague of mine from the University of Pittsburgh, who is an oncologist, director of adult neuro-oncology, who's doing some extraordinary work. This is where I said the benefits can be stranger than you imagine, with tumor-treating fields, clinical trials, and mechanisms. Dr. Lieberman, I'm delighted to see you here. Thank you.
Thank you. So I'm grateful to be invited, and I'm humbled to be here. I actually see the faces that go with the names of many of the papers about the basic science of this technology that understand it far better than I do. I think it's also fair to say that Deborah's incorrect in saying that this is my work. This is actually, we were a collaborating site in a clinical trial that was developed by very innovative biotechnologists and basic scientists in Israel. And I actually pointed out to Deborah that the people that really know the most about this are located 20 minutes away at the Weizmann Institute. She pointed out to me that actually they've moved to Switzerland because the company moved to Geneva. But this is really Israeli biotechnology. So we're talking about a technology that generates electromagnetic fields through the head, basically. And it creates an electromagnetic field that is using energy between 50 and 200 kilohertz with a field strength of about 1 volt per centimeter. So by putting electrodes that go on the head, you can actually penetrate these electric fields at that strength to conform to the shape of a tumor inside the brain tissue. This is optimized by a computer software algorithm that designs the electrode grid that the patient wears on their head, like we can see in this picture here. So the company actually points out that in the latest edition of this device, the battery pack that he's carrying is much smaller, but the electrodes on the head are still obviously very visible. So there have been several clinical trials that have looked at this application of this device. It was designed to treat tumors that were primarily problems as local disease. In other words, you're not going to be able to treat metastatic disease with this device, but cancers that cause morbidity and mortality by growth in one spot are good targets for this. And the company decided to use a type of malignant brain tumor, actually the most malignant type of brain tumor, as their first clinical trial challenge. The results have actually been transformative in the world of neuro-oncology. I have to say that one of my prescient insights in this is when many of my colleagues were skeptical about this, I pointed out to them that many people had become impoverished underestimating Israeli biotechnology firms. So I want to take just a moment to discuss clinical trial endpoints because I think it's going to be helpful to understand the trial design. So in looking at whether a treatment of cancer is effective, the highest bar, and in many ways the most robust measure, is that a treatment improves overall survival, how long the patients live. In situations where the overall survival is going to be affected potentially by a series of treatments, and you want to know just about the efficacy of your treatment, another endpoint that you can look at is whether your treatment prolongs the time it takes for the tumor to grow again. That's called time to progression, or progression-free survival. For a device like this, where it's possible that it would control local disease, but metastatic disease outside the body might lead to death, another site in the body might lead to death, there's a criteria that's called in-field progression. So for instance, a clinical trial that looked at lung cancer, the device might work on the cancer in the lung, but not metastatic in other organs. And then, if we're looking to see an early, rapid evidence of a biological effect, we can look at what's called radiologic response rates, meaning the tumor gets smaller. The complete response, the tumor goes away. The partial response, it shrinks partially. Stable disease, it doesn't grow. And there's a combined value that's called the clinical benefit rate, which combines the percentage of people who have complete response, partial response, and stable disease. Okay. So the first clinical trial for glioblastoma, which is a malignant brain tumor for which the survival in newly diagnosed patients is about 1.5 to 2 years, and in recurrent disease is about 6 months, was a clinical trial that compared using the tumor treatment fields in patients with recurrent glioblastoma and comparing that to chemotherapy that the clinicians suggested, because for patients that have recurred more than once, there's really no standard therapy. So this study had an interesting result. It showed that the tumor treatment fields were no worse than the best chemotherapy, but there were fewer side effects. So in the United States, the FDA approved the device for use in recurrent glioblastoma based on the fact that it produced fewer side effects than the standard therapy. In this particular study, there were a number of patients who had clear radiologic responses, including one of our patients who had a response while he was wearing the device, stopped wearing the device, the tumor grew again, he started wearing the device and the tumor responded again. So there's clear evidence from even these early clinical trials that the tumor treatment fields have a biological effect. But the transformative study was a large clinical trial that was done in Europe and Canada by the European Clinical Trial Group that was headed by Roger Stoop, the person who had designed the clinical trials which established the previous standard therapy as the standard of care. So what this clinical trial did was it took patients who were receiving the standard treatment, which is 6 weeks of radiation therapy, 1 treatment per day, 5 days a week, with chemotherapy given every day during the radiation, including the weekends, even on the weekend days when there's no radiation being given. Radiation oncologists may be aware that there's a poorly understood biophysical principle that tumors don't grow on weekends, so you don't have to treat on Saturday or Sunday. Then after the 1 month break, when the standard therapy started follow-up chemotherapy, in one group, the tumor treatment fields were also started. In the other group, they got just the chemotherapy. So this study showed that there was an improvement with the addition of the tumor treatment fields, both in progression-free survival and in overall survival. And the magnitude of the benefit of adding the tumor treatment fields was actually a little bit greater than the benefit that was reported in adding the chemotherapy in the clinical trial that made Roger Stoop famous. So Roger has pointed out in several meetings where people have been skeptical about the value of the tumor treatment fields that the improvement in survival of adding the tumor treatment fields is actually greater than the benefit of adding the chemotherapy. So this study, although the neuro-oncology community in Europe and the United States is still digesting the results, I think it's clear that this has established the technology as an effective treatment in prolonging overall survival in newly diagnosed glioblastoma patients. The clinical trials groups in the United States and Europe are just figuring out how to include this in clinical trials of further therapies, but it's pretty clear that this is going to become part of the treatment of newly diagnosed glioblastoma. There have been several other clinical trials that are looking at other types of local tumors, which also have shown very promising results. One is in locally unresectable newly diagnosed pancreatic cancer. This is another cancer that develops locally, is usually locally extensive at the time of diagnosis, and causes a lot of morbidity, especially pain and GI problems, bile obstruction by local progression. So it's another setting where an effective local therapy would potentially produce an increment of value. And here, in a small trial that looked at 20 patients and compared the outcome of adding tumor treatment fields to one of the standard commonly used chemotherapy arms, there was an improvement in progression-free survival and overall survival, and also almost a little bit over a doubling of the percentage of people that were alive at 1 year. And there also was a tripling of the percentage of patients who had partial responses. So that's important in pancreatic cancer, because one of the big issues in pancreatic cancer is at the time it's diagnosed, it's usually too big for surgical removal. For patients where the tumor can be shrunken down to the size where it can be surgically removed, they have significantly longer survivals. So there's all sorts of complicated, highly toxic chemotherapy regimens to try and shrink the tumors down. And here there's a relatively non-toxic strategy that may accomplish the same thing at a higher rate than chemotherapy does. This is almost certainly going to become part of pancreatic therapy, in part because it's easier to convince people to wear the electrodes under their clothes than on their hands. There's a second pancreatic cancer study that's in recurrent disease that is a little bit more preliminary data, but is also showing that the progression-free survival and the survival at 1 year is significantly better than very recent historical controls. There's also a clinical trial going on in a recurrent ovarian cancer, which again causes a lot of morbidity by local spread. And here, again, there's a progression-free survival rate that's double that, a progression-free survival length, rather, that's double that of historical controls. And in brain tumor therapy, there's preliminary evidence that a very treatment-resistant situation in glioblastoma therapy, after the tumors have been treated with an anti-angiogenic drug called bevacizumab, where the median time to progression is only 2 months, and most people are dead within 12 weeks, the tumor treatment fields are superior to chemotherapy in terms of overall survival. They almost double the overall survival. Lastly, in this list, but one of the first studies to be presented at the cancer meetings in the United States was a trial in non-small cell lung cancer, which took patients with locally advanced and metastatic disease, focused on treatment of the disease in the chest, adding the tumor treatment fields to one of the standard chemotherapy regimens. And this study demonstrated that the time to progression in the field was improved. Progression-free survival overall was improved. There was a higher percentage of partial responses, and the median survival in that study, even though many of the patients had metastatic disease, was almost 3 times longer than historical controls, and the 1-year survival was substantially higher. So in conclusion, there's a series of clinical trials, some of which admittedly are very early, one of which was a very well-powered, multi-centered phase 3 trial that have demonstrated that these tumor treatment fields, which use this very specifically designed radiation, usually 150 to 200 kilohertz, 1 mol per centimeter, to treat tumors that cause mortality and morbidity by local progression, and it's demonstrated efficacy. So I think this shows, there is a biological effect to these electromagnetic radiation. So thank you very much. I did it.